Hello everybody, and welcome to the GHP Brown Bag series. My name is Jacqueline Bob. I'm a member of the department, for those of you who don't know me. And I'm delighted to introduce my colleague and friend, Professor Melani Cammett, who many of you will know because she's actually affiliated with our school, and she has a secondary appointment at the Chan School, even though her primary appointment is in the Faculty of Arts and Sciences. Professor Cammett is the Clarence Dillon Professor of International Affairs in the Gov Department, and she is now also the director of the Weatherhead Center. She has a long history of working on issues to do with the Middle East, with displacement, with conflict, and her voluminous CV and publication record attest to that. A couple of highlights from that. She's a co-editor of something called the Oxford Handbook on Politics in Muslim Societies. She wrote a book called Compassionate Communalism, Welfare and Sectarianism in Lebanon in 2014, which won the American Political Science Association Giovanni Sartori Book Award and was an honorable mention for the APSA Gregory Lovett Book Award. She co-authored a book called A Political Economy of the Middle East. She co-edited a book called The Politics of Non-State Social Welfare in the Global South, and another book called Globalization and Politics in North Africa. And she's currently writing a book comparing conflicts in Bosnia, Northern Ireland, and Lebanon. And she's actually reaching us from Belfast today. So Melani, thank you very much for joining us. We're very much looking forward to your presentation on your research on international organizations and their effect in refugee contexts. Couldn't be more relevant at the moment. So thank you again for joining us. We look forward to hearing from you. Over to you.
Great, thank you so much. I'm really pleased to be here, and really thanks to everyone for showing up. I'm going to share my screen to pull up the slides. I'm getting two versions of this. Let's see. Okay, let me just make sure I have the right version. Okay, I think this should work. Great. So I'm going to talk about a paper that's actually forthcoming in a journal. So if you have lots of critiques, you're welcome to share them with me, but there's probably not much I can do about it at this point. So the paper is, as you can see, entitled what we call the IO effect, the International Organization Effect, International Actors and Service Delivery in Refugee Crises. And it's co-authored with Aitu Shashmaz, who's a postdoctoral fellow at Stanford and is an incoming faculty member at Bryn Mawr College. Whoops. Okay, so let me say a bit about what we're focusing on here. We are looking in Lebanon. I'll get to that in a minute. But the larger issue that we're looking at is the phenomenon of displacement and humanitarian crises, which are obviously quite widespread across the global South. And there's a large and growing literature, and I know Jackie is quite familiar with this, and this touches on some of her own work, that documents the resentment and hostility that refugees face in host communities. What we know less about is how refugees experience social service delivery in the host communities where they're based, and whether this resentment and hostility somehow spills over into the experience of what they experience at the facility level. And so our focus is on Syrian refugees in Lebanon. And the conventional wisdom in this literature I alluded to on host country attitudes towards refugees is that refugees face hostile attitudes, and that we can expect that they would face discriminatory experiences at the facility level or in their interactions with host country nationals. Much of the research is based in this literature on mass public opinion, but there's lots of evidence to show that these negative attitudes also are held by educated elites, including in Lebanon. Certainly, if you look at public opinion data and you break it out by levels of education or socioeconomic status, you do see negative attitudes reported towards refugees in recent rounds of public opinion polls in Lebanon. We have in our project also a conjoint experiment that looks at the attitudes of doctors in particular towards working in facilities with majority Syrian refugees as the patient base, and they express negative attitudes towards this across the board. So there's some evidence that this even extends to educated professionals such as medical doctors. At the same time, we know from a variety of sources that pro-social behavior is possible, including towards refugees by host country nationals. And although there's less literature in studies of host country national attitudes and behaviors towards refugees that looks at the positive side, there is some, and it's growing. And I know actually this is, again, some of what Jackie's work is looking at right now. And so it is entirely possible for a variety of reasons that refugees would face positive experiences and relatively equitable treatment in host country facilities. And this could arise because, of course, of intrinsic motivations, altruism. People are altruistic, and that is a valid motivation that is documented. And of course, in professional sectors like medicine, which is our focus here in primary healthcare, professional values come into the mix. So doctors, in theory, are committed to the Hippocratic Oath and want to provide equitable treatment to their patients. There's also extrinsic motivations, which might explain pro-social behavior towards refugees on the part of host country nationals, and particularly on the part of educated professionals like doctors. So financial incentives, of course, are one factor, and that's been documented in work in other developing countries to motivate doctors to exert themselves more and to treat their patients better. And there's also strategic motivations. For example, many of the doctors in our sample, and I'll talk about this in a minute, come from non-state organizations, whether they're religious or political or just unaffiliated non-sectarian NGOs, and they may be motivated to make the organization that they work for look good. So there's a variety of motivations, intrinsic and extrinsic, that might explain why you have relatively equitable behavior. Okay, so I want to preview what we find, and then I'll talk about how we find this and what our data and methods look like. So we look at how Syrian refugees are treated in Lebanese health centers, and we, to get to the punchline, we found, and in some cases even better than Lebanese nationals in the same facilities. And let me just say a quick word about these health centers. So in Lebanon, there is a network of 220 something or more at this point, primary healthcare centers that are run mostly by non-state organizations, mostly by private nonprofit organizations. About a quarter of them are affiliated with either the Ministry of Public Health or the Ministry of Social Affairs. So those are the public ones, but the other 3/4 are run by these other categories that I've just referenced. So political parties, religious charities that are not linked to parties, and non-affiliated, non-sectarian NGOs. So these are the centers that we're talking about, and they tend to cater towards poor and lower income people. We did this data collection a number of years ago before the complete economic meltdown in Lebanon. So I would imagine these places are treating a lot more people now because the poverty rate is actually approaching 65, 70% right now. It's a real disaster in Lebanon. And this is also the network of health facilities that, that the Ministry of Public Health used in collaboration with the World Bank to roll out a sort of quasi-universal healthcare program where people would have access to a low-cost package of benefits. And so we find, again, that Syrian refugees receive relatively equitable care in these facilities. And we make the argument that the reason they do is because of the effect of international organizations in bringing up the performance of facilities linked to them, which brings up the average effect of quality for Syrian refugees vis-a-vis Lebanese nationals. And I'm going to go through the logic of that argument later, but just to briefly foreground it, basically, some of these facilities have partnerships with international organizations like the UNHCR, and that gives them a bunch of resources and benefits that are attractive. In general, also, a lot of Lebanese professionals want to work with international organizations because the terms of the jobs are better and so forth. So there's incentives to bring up the quality of care when you're working in an organization that provides care and is linked to an international organization. But I'll elaborate this a little bit more later. So let me talk about the study itself. And again, our focus is on primary healthcare clinics in Lebanon. And I described their affiliations and how they're structured in broad terms. And we carried out extensive data collection at the facility level. And for those of you familiar with some of the work that Jishnu Das and his collaborators have done in measuring the quality of healthcare, primary healthcare in a variety of developing countries, starting in India, we were inspired by that approach. So we modeled a fair amount of the data collection off of that approach. And so we have an original sample of 69 centers. And within those centers, we had an excellent team of researchers that we personally trained in Lebanon. Our team carried out surveys with about 200 doctors that included this conjoint experiment I referenced earlier. They carried out survey interviews with about 1,200 patients as they exited the facilities. They observed about 1,200 medical examinations, and they carried out, one of our researchers on the team carried out follow-up interviews with doctors in a random selection of centers afterwards to help us dig through some of the findings. And the data are matched across centers, doctors, and patients. So we can, have observations that link a patient to a particular doctor in a particular center. And so how did we measure the quality of care? And again, here we followed Das's approach for the most part. But let me talk a little bit about how this is structured. So our key variable of interest is the nationality of the patient, Syrian versus Lebanese. And the outcome of interest is the doctor effort index, which is based on a composite index of the number of questions that doctors asked, the number of physical examinations that they carried out, and the number of, and how much time the doctor spent with the patient. So this is really tapping into what Das and others have called process quality. And we do have, all kinds of data also on the sort of infrastructure at the level of the facility and so forth. And so we thought this was a good measure based on arguments that Das and others have made, that this is really an important factor. How much effort the doctor exerts is a really critical factor in shaping patient health above and beyond the quality of the machinery, equipment, resources in the facility. And we have a variety of control variables in the analyses that tap into age, gender, socioeconomic status, the religiosity of the patient, and then a variety of health-related controls like the type of visit the patient was on, you know, sort of what they were there for, a self-assessed health status measure, the number of symptoms that the patient reported, and then we included a measure of the order of the examination, of the observed examination of a given doctor, to try to address the question of Hawthorne effects, because various people, again, DUS, have made the argument that the more examinations the doctor conducts, the less subject to Hawthorne effects. And then we also included measures of what kind of center the doctor was based in, where the examination took place. Was it a public sector facility? Was it one of these non-sectarian NGOs? Was it a center from the patient's own religious affiliation or from another religious affiliation? Because we found in other work that that does affect both the quote unquote objective and subjective quality of care that patients receive in Lebanon. And we include cluster robust standard errors at the provider level. So that's a sort of general overview of how we approach the quantitative portion of the data collection. And just to give you a sense of where we are, of the key variables in our analyses. Let me just pull this over. So again, the key variable of interest is the nationality of the patient. And then we have a variety of measures that we use to construct the dependent variable, and find a little bit of difference there when we compare the means for Syrians and Lebanese in favor of Syrians, actually, and then a variety of control variables. So let me just jump to the results, because I know I only have like 10 more minutes here. Okay, so here's, I just included the main variable of interest here, the nationality variable. And just to give you a brief overview of what we find, and then I want to go into more detail of how we try to explain what's going on. We find that when we don't include fixed effects, there is a slight advantage for Syrian patients in terms of the quality of care measured by this process quality index that we've constructed. But that goes away when we include both center fixed effects and provider fixed effects. And these models all include those variety of control variables I mentioned. They include enumerator fixed effects, and we did a robustness check with the symptom indicator variables as well. So, so what do we take away from this? Basically, when we include those models with fixed effects, it eliminates the positive significance of the Syrian variable, which suggests that there's something going on at some types of centers and with some types of doctors who are exerting more effort with Syrian patients that's resulting in this average equal treatment across Syrian patients and Lebanese patients. So we want to dig into that and try to figure out what's going on in those particular places. And we have a variety of measures in the survey that are designed to tap into potential motivations for this seemingly pro-social behavior. So we have a measure that looks at the motivations for why a doctor wanted to work at the particular facility that suggests that altruism was driving it. We have a measure that looks at the professional motivations to work at a particular place and for doctors to practice their profession. And then we have measures that look at whether they work in centers that pay in a certain way that might be more likely to want them to have more patients if they get paid on a per patient basis, for example. And then we have a question about whether they're concerned about the image of the organization and whether the image of the organization where they're working was a motivation for them to work there. So we try to use these proxies to test whether these might be mediating the effects here. And so we basically use them in an interaction, in a regression, interacting each of these measures with the Syrian national identity variable, and we don't find significant results when we add these potential moderators. So that doesn't suggest that these are the things that are going on, differentiating these doctors. So then we turn to what we've called the IO effect, and to see if there's something going on with the involvement of international organizations with the particular centers that seem to be delivering better care and bring up the average that Syrian refugees are experiencing in these facilities. So let me just give a little bit of background on what these international organizations are and what's going on here in the humanitarian crisis in Lebanon that made us think that this might be part of the factor, part of the explanation for what's going on. So as in many conflict-affected contexts, as is the case in Lebanon, there's a lot of international organizations operating there, and they tend to spike when you have a crisis. So when you had the war, the civil war in Lebanon from 75 to 90, you had a kind of influx of international organizations that tends to sort of reduce a little bit in calmer times and picks up again. And over the years, I've done a lot of work in Lebanon, and I've often had people talk about how that creates kind of incentives, local incentives to try to attract support from these international organizations. And there's a large humanitarian sector there dominated by international, or that has a lot of international organizations. There's also a lot of local humanitarian organizations as well. And when the Syrian refugee crisis first started to really spike in 2012, and people started in 2012, 2013 pouring over the borders into Lebanon, it's well documented that there wasn't a coherent plan for dealing with this crisis. And it wasn't until, I believe, 2015 when the Lebanese government, the Lebanese Ministry of Public Health, coordinated with other, with international organizations like the UNHCR and WHO to work out a Lebanese crisis response plan that really systematically tried to funnel resources from international organizations to facilities and to help support the response to deal with the crisis. Because in Lebanon, you don't have refugees living in camps the way you do in Jordan, for example. So Lebanon decided not to have camps for, that's a whole other story related to the history of refugee crises in Lebanon. And so Syrians are kind of dispersed throughout the country. There are some settlements, kind of informal settlements, but they're all over the country. And the Lebanese schools and these particular facilities that we're looking at were the key welfare institutions that were trying to serve Syrian refugees and children. So in 2015, these groups got together and started trying to coordinate humanitarian efforts, and this involved designating certain centers as partnered with some of these international organizations to receive support, and in return, they would serve Syrian refugees. Now, Syrian refugees are in all these centers, but some of them were selected to receive international support. And so the centers were pre-existing. It's not like the UNHCR created new centers. They were pre-existing, and the partnership deal provided subsidies to these particular centers, guidance on medical practices and some equipment, and a number of them were directly funded by the UNHCR. So we got a list of these centers. We did data collection for this phase of the project, for the quantitative phase, in 2017, I believe. Yeah, 2017. And so we got a list of centers that were partnered with international organizations, not just the UNHCR, through the Lebanese crisis response plan, and created an indicator for whether the center in our data set had that partnership or not. And so we wanted to look at whether partnered centers delivered better care to Syrians. So if this was the distinguishing factor. And so basically what we find is that is the case. And that, we ran analyses interacting IO partnership with the Syrian variable, and found that in fact was that was significant. And in fact, being Syrian as a significant variable associated with improved quality of healthcare disappeared when you include this interaction term. So the effect of being Syrian in a center with a partnership versus being Syrian in a center without a partnership is tangible. And it actually corresponds to several extra questions being asked by the doctor and more time on average spent with the doctor. And these look like small amounts here, but they're actually quite significant when you look at the baseline of how much time doctors spend with patients. So it does seem that there's something different going on with partnered centers, with centers that have these international organization partnerships. So we wanted to look at what exactly is going on, what might be the mechanisms underlying this. And we certainly had some ideas from having spent a lot of time in Lebanon and done work there over the years. But what we did, as I mentioned earlier, is randomly select a number of centers and doctors within those centers for in-depth qualitative interviews to try to dig into what's going on. And one of our researchers carried them out after we did a training session with her. So I just want to mention a few quotes from the qualitative data that I think help to illuminate what's going on here. One doctor mentioned, and these interviews were conducted in the fall of 2018. One doctor mentioned that centers that helped a lot of Syrian patients prospered, and that helped to advance the center. So it was increasing the flow of patients to the center and generally leading to the sort of flourishing of the center. So it was viewed in some ways as a positive thing for the center. Another doctor mentioned that doctors took advantage of the situation with the influx of Syrian refugees and saw this as an opportunity and experienced this refugee displacement period as refreshing for the centers. They got more machines and support, they got to hire more doctors, so it was a motivating factor to treat more patients. And then conversely, when the aid started to drop off a little in certain centers, one doctor noted that the level of care dropped and that the Lebanese healthcare system without this support can't help Syrian patients. And I want to emphasize that these were not prompted by our researcher telling the doctors, this is what we found, can you explain it at all? These were sort of unsolicited comments in the course of an open-ended set of interviews. So just to kind of wrap it up and sort of think a little bit about the broader implications here, we think the research sheds light on the importance of international organizations and their relationships in conflict-affected countries. And for those of you familiar with international relations literature in political science and social sciences, international organizations often have kind of a bad name in some ways. There's a lot of sort of critiques of the role of international organizations because of particular distortions they might set up in local economies and related issues. So where our paper, we think, is contributing to those debates, and we're noting a sort of distinct effect of international organizations in these contexts as a key provider of resources addressing crises, as a potential stream of resources for future crises, and as a major employer for educated professionals. So this is something I haven't emphasized enough yet here, but we go into in the paper as part of the mechanisms that we think are underlying this, is that the organizations that form these partnerships with international organizations have an incentive to maintain good relations with IOs, because they are a potential stream of resources in the future. So they want to maintain this good relationship. And likewise, at the individual level, educated professionals in Lebanon, and frankly in many other conflict-affected countries, are often employed by international organizations. This is a major employer. And in fact, there's an entire literature on this, I think in economics, that looks at internal brain drain as a phenomenon, because you have educated professionals going to shift over to the IO sector to work there. The compensation is usually higher and the benefits are usually higher. And there's sometimes a status bonus as well. So there's motivations at the organizational level and the individual level to maintain positive relationships with international organizations. Of course, there's a downside here, and this relates to that literature on international organizations. Often these partnerships are unsustainable because, as I alluded to before, there's a kind of boom-bust cycle in conflict-affected countries where you have an influx of international organizations coming in during crisis times, and then they start to move out. So it isn't a sustainable resource flow. And there's also the phenomenon of internal brain drain, which is kind of a double-edged sword. On the one hand, educated professionals remain in the country. They're not going overseas if they're working in IOs locally, but on the other hand, local organizations might lose some of these more educated professionals. And you know, we've been thinking about what the scope conditions are for this argument. I think you know, I can imagine that this would apply to a number of other developing countries with under-resourced welfare regimes. I've been sort of just thinking off the top of my head, with so much news on Ukraine these days, whether we would ever expect something similar in that kind of context. And on the face of it, you know, I would say no. You have a very different relationship between host country nationals and displaced Ukrainians, with generally a much more positive reception for a variety of reasons. But you know, perhaps over time, if the host country experiences economic pressures or fatigue itself, maybe you would see similar dynamics. But generally speaking, we think our argument applies more to developing countries with under-resourced welfare regimes. So thank you very much. I will stop there.
Thank you very much, Melanie. It's really a fascinating paper, as I told you before. And I have a bunch of questions, but I'm going to open it up to my colleagues first to see who would like to start the discussion. So please raise your hand in whatever way if you have a question. Michael. Oh, Michael's disappeared. Kevin. Okay, Kevin, and then Jesse.
Sure. Thank you so much, Melanie. It's a really fascinating paper. I was really struck by some similarities with some of the discourse that we had been hearing for many, many years about external aid flows in highly aid-dependent countries in low-income countries, many in sub-Saharan Africa, also South Asia and other regions, where it's sometimes argued that, you know, when an external donor, you know, for HIV or other specific diseases kind of enters the picture, those clinics get much more resources, and providers can be recruited specially to work in those schemes. And it seems like there's some similarities with the dynamic that you're mentioning. I wonder though if there wasn't a kind of a further puzzle in the last result that you showed. So I sort of was following the argument that you have this favoritism, even slight favoritism towards Syrian patients, or kind of higher quality care that goes away with the fixed effects. And so it's got to be a between center issue. But then I seem to read that in the last slide, you were showing that even in those highly resourced centers, the Syrian patients were getting, I think, slightly better care, if I was reading that right. Is that the right reading?
Oh, it was, sorry, Syrians were getting better care in facilities with IO partnerships.
Right. Yeah. And so I guess, and then all of the qualitative work said, well, these facilities got more money, they're better resourced. And so that kind of makes me understand why they'd be doing better in general, but why do you think even within those better resource facilities, they were sort of having this differential or higher quality of care for refugees?
So I mean, I think what's going on is that there's concerns to show that you're good to refugees. And so I think that's probably what's driving this, is this effort to show that you are fulfilling the terms of the contract, and the center's fulfilling its terms, and the doctors are fulfilling their terms. But one thing we didn't put in the paper, we have a very long supplemental appendix, and we have more qualitative data in there, in addition to the survey data that we reported, that I referenced at the outset. There's really unbelievable qualitative quotes where doctors say really discriminatory things quite openly, to our researcher that went back and did the in-depth interviews. And also we had the enumerators write notes, at the end of every site visit. And there's really unbelievable quotes like, that Syrian refugees are dirty or unhygienic. And, when I read the literature in American politics on racial congruence and, race-based discrimination in the quality of care that African Americans get in health centers in the US, and you hear the language that's associated with it, it's exactly reminiscent of that. It's the same stuff. Like they don't know how to follow medical advice, or they're not smart, or those kinds of things. And that was true in facilities where these doctors were working. I mean, we in an earlier framing of this paper, we called it equity with prejudice, but we felt like we couldn't systematically show the prejudice quite so clearly. I mean, everyone I talked to in Lebanon who knows this sector is like, oh, it's absolutely going on, but it wasn't quite as systematic. But yeah, so this seems to be going on despite levels of prejudice. So it seems to be these motivations having to do with performance for international organizations.
Thank you. Jesse.
Yeah, thank you. Thank you, Melanie. I'm a big fan of your work, and it's really a pleasure to see some more of it here. I was really interested in this paper, and I think its findings are important. I want to talk about the interpretation. So I'm sure if the international organizations find out about the paper, they're going to use it to justify their presence. They'll say that we're converting money into good care, we're doing things, and they will paint a positive picture of themselves. And to my way of thinking, it's that interpretation is pretty sensitive to the comparison. So I wonder, do you have a sense of whether the internationally linked centers are maybe more efficient or less efficient at converting their superior resources into care? And whether, and then as a related question, I would like to know your thoughts on what's a good end game, right? So if your paper disturbs the political economy of refugee care, like where do you want that field to go? Like, should there be a permanent international cadre that goes around wherever there's problems and they do what you're seeing here? Or should we think more about building capacity or something else? I'd just like your thoughts on that.
Yeah, no, this is really, this is the uncomfortable part of this paper. So
yeah.
Thank you for asking that. And it's kind of made us a little bit gun shy about it a little bit. So, I mean, we do have these center and provider fixed effects. So, when the same center, same patient. So it seems to be something about this interaction with the Syrian patient, in particular centers and providers, and that seems to be distinguished by the IO relationship. I mean, we do control for a whole bunch of other stuff, and it's hard to say. I mean, the other thing that we do find is that doctors, I don't have this here, but in the paper we show that doctors that work in these facilities with IO partnerships report higher levels of job satisfaction. And so that might be linked to the benefits and so forth, and the way it's run. I mean, we couldn't do, in the ideal world, we would have done random assignment of patients, right? But we absolutely could not do that for ethical and logistical reasons here. So it's hard to really isolate exactly what is going on. But it, and the facilities are definitely located that get IO support tend to be located more near clusters of areas where refugees are based. And, the UNHCR has done a number of surveys, so they have a sense of where refugees are based in the absence of camps. But yeah, I mean, other than that, we don't have a sense that they're inferior centers. And it might be that you have centers in the same network, run by, say, the same religious organization. One is in the partnership and one is not, and the patients are getting better care in the partnered center. But I think the really hard question is the one you ask about the sort of implications of it, because it's kind of disturbing a little. I mean, we don't want to be like, yay, international organizations are doing everything right. And it's true that they are aware of this paper, the UNHCR, and I don't think they object to it. So it's hard to say what the takeaway is. I don't think it's as simple as send the IOs in and they'll save everything. I would like to sort of flip it more towards what you were getting at, which is build local capacity. And I think to some degree that's what the IOs are doing here, is they're not directly providing, they're giving resources to organizations locally, but they're not doing it to every single one. So there's sort of inequality and variable capacity building. And as I said, in the end, the one thing that's concerning is this aid is not going to last forever, right? And it's not clear that the effects are going to be felt longer term. I mean, we don't have a follow-up study that's looking at what happens when the IOs leave. I wish we did. Yeah, so I don't have a great answer to that, but it does seem to have a positive effect in the immediate term. Whether that lasts is another question.
I mean, I think that it's a good thing to chat about, and we should catch up on it. I just published a paper also with Turkish co-authors about the effect of Syrians on the Turkish health system, right? So they didn't do this external, IO, NGO delivery. They manage refugees through the entire Turkish health system.
Yeah.
But because of the different concentrations of Syrians, you can measure some system-wide effects. It could be interesting comparison chat. So
yeah,
you and
I mean, the
can
Turkish
catch up
health
on.
system has so much more capacity than the Lebanese health system. So
Yep.
it's really a different context, but we should definitely talk. And I would love to think more about the implications of this. Maybe we could write something about that.
Yeah, sure. Sounds good. Thank you.
Yeah.
Michael.
I can't hear.
Sorry, my bad. Here I am. Thank you, Jackie. Thank you, Melody. It's great to see you. And thank you for your participation in the department and the school and the university. Thanks also for the paper. I'd like to ask a slightly different take on the paper.
Mhm.
And that's on the role of partnerships. So in a study that I did with Martin Lejeune in Mexico on treatment of childhood cancers in facilities around Mexico, we found a distinct difference in survival rates for those hospitals that had partnerships with US institutions. So there is in healthcare facilities both a literature about partnerships, a literature about twinning, and a literature about the way in which connecting institutions together can have a positive effect on the, let's call it, the institution that's participating in the low resource center. And some of that is training, some of that is actual people showing up, Some of that may be a kind of Hawthorne effect. Some of that may be more resources. Some of it may be specific equipment, maintenance of equipment, all kinds of different effects. And so I would just like to know your thoughts on that. So it's not necessarily the international organization, but it really is the nature of the partnership. And if you found any difference among different institutions with different kinds of partnership relationships.
Well, this is a great question. And I think I can't say that we've dug into the data and looked at, a partnership with UNHCR versus another international organization, whether that varies, but that's a really good thing to do. We could do that probably more more descriptively, given the small, once we slice and dice, we'll probably get into small sample size, but that would be an interesting thing to look at, whether there's variation there, because certainly the benefits of partnership that you describe are along the lines of what we're talking about here. Exactly. The difference is, I would imagine, I'm guessing this with these cancer center partnerships, is that there's a kind of continuity to them, that they establish a contract that goes on for years, or no? Or is it more short?
It depends. Some of them go on for years, but I think this is a broader question of kind of organizational learning and improving organizational performance through, and especially in the Zoom era now, with not physical presence, but improving the capacity for diagnosis, improving judgments about treatment, even referrals of specific cases. And I think it really has to do with a kind of globalization of care that can happen in low resource settings. So I think you've been looking at it mostly from the international organization. I'd encourage you to give some thought to sort of the differences in strategies in partnerships and potentially different impacts on improving quality of care.
Yeah, that's great. Yeah, I'll look into that, because we do code for the different partner. And we have that data. Yeah.
You're on mute, Jackie.
We're in this Zoom era.
I know it's only 2-3 years into it. I was saying that we only have now 11 minutes left, and we have 3 questions because I've added myself to the queue. So in the interest of getting all our 3 questions in, Melanie, may I ask Steve, Carmen, and me to just put our questions to you, and then you'll have a few minutes to respond and sum up, if that's okay. So Steve.
Thank you, Jackie and Melanie. This was fantastic. I'm so interested in reading the paper when it comes out. I did spend a lot of time in Lebanon, and I've worked for international organizations for several decades. So my question has to do with the political context surrounding the presence of UNHCR and the other IOs that are influential here in providing this assistance, because it's not in the context of a peacekeeping operation under the authority of the Security Council. It's more like OCHA, although I didn't see you mention OCHA. I don't know what OCHA's role is in this. But so my question has to do with the politics, both of the Lebanese government. Are there certain pressures because of the different contending factions involved there, and the constraints on the Lebanese economy on the one hand, and of the authority channels for international organizations on the others? Does it go through OCHA? Does it go through, what are the authority channels, and how does the politics influence the effectiveness of providing this type of medical assistance to the refugees? And does that influence the attitudes that you're talking about? Would it be different, for example, a word under a PKO? Would it be different? Is OCHA doing a good job here? Could it be different? differently done in light of the politics? So that's essentially my question.
Mhm.
Thank you, Steve. Carmen.
Hi, Melanie. I really enjoyed your presentation. So thanks for this. It's really fascinating research. My question builds a little bit on Jesse and Michael's questions, and I'm trying to better understand the IO effect and what exactly is doing the work in explaining these outcomes. So you had mentioned that it's because these centers have the desire to show they're fulfilling their commitment to IOs. So are you saying that healthcare providers are doing this because they're hoping to continue to access cash and resources with the goal of future revenue flows? Is that what's doing the work? And then are the implications then that, then it's the potential for future cash revenues that, I mean, what you're suggesting then is that the potential for future cash revenues can actually overcome discriminatory attitudes towards refugees and migrants. So I was just hoping for a little bit, if you could talk a little bit more about that, that would be great. Thanks.
Melanie, I think it's a terrifically interesting paper with so many potential spin-offs. My question, though, is to something kind of quite fundamental, which I think we haven't discussed, which is really to interrogate a little bit the notion and the ingredients of your definition of what quality consists of. You said that you also did interviews with patients, but I don't think you discussed that. And clearly, other things being equal, a doctor spends more time with the patient is better than a doctor spends less time. But it may be that because they're refugees, they have more complicated histories. It just to get to the same baseline, you take longer. Doesn't necessarily mean that the patient experiences a higher quality of care. And I don't know if Margaret, I don't think Margaret's on this call anymore. I think she was, but I think if I remember rightly, the work that she and others have done on quality of care, a lot of it has to do with how the consumer evaluates the care. And I wondered whether you looked at that at all. I mean, then the other data you showed suggested actually what's going on here is that the centers are doing well. The service provider is benefiting from the international organizations, but they have more resources and so on. Doesn't necessarily mean that the patients are experiencing a great level of care. So I just wanted to ask for your reflections on that, please. Thank you. And I'll now hand the mic back to you to conclude and to respond to these questions. Thank you.
Mm-hmm. Mm-hmm. Okay, great. I think these are great. Thank you so much for all these questions. And Steve's question about the political context. I mean, it's clear that he spent time in Lebanon because he knows this is a really complicated thing and that it's hard to talk about the Lebanese government because there are so many factions involved in this. So I'm not sure I have a great answer about this. I mean, I can speak more about the political context of the different types of providers. But prior to 2015, there basically was no organized Lebanese government response, and it was just very haphazard. There's been work done showing that the response was incredibly decentralized, and the experience that refugees had in host communities varied tremendously by municipality, depending on the politics of different municipalities. So really what happens in 2015 is the government, I think under the office of the prime minister, negotiated this Lebanese crisis response plan, of which the Ministry of Public Health was a key actor involved. And so it was all of these groups together negotiating it. I'm not sure if I can really say if it would look different if it were under a different structure, partly because I'm not, an expert on the way that international organizations conduct these negotiations. It's actually not my sort of area of expertise. But it definitely brought some coherence to the system, which was really incoherent before. I mean, really incoherent and very haphazard in terms of, the experience that people had at different facilities. So these are the other questions are also great and tough. So on the IO effect, what exactly is doing the work? So what we're arguing is essentially something akin to what you've just described, which is that there are these material incentives, and they're not just money, they're also potentially status, and sort of a variety of benefits, which I guess could be, transformed into money, that seem to be the distinguishing factor. And I mean, I don't want to, it sounds horrible. I don't want to imply that there isn't altruism at play. I mean, certainly we know that. And we actually have another paper that was based on a pilot study here that shows that different types of facilities tend to attract more intrinsically motivated providers. So that certainly is a factor involved here. And I can tell you many, examples of people I know who are doctors working in these facilities who are motivated by altruism. So it's certainly a factor, but on average, when we're talking about what distinguishes the IO sector from others, it definitely is associated with higher pay, more prestigious jobs, better benefits, and so forth. And you do tend to see a lot of really educated professionals trying to move into that sector for those reasons. And, we discovered in the course of working on this paper that there's actually an entire literature on this, on internal brain drain, so it's a phenomenon in other places as well. So that's what we think is going on. And I suppose an implication is that if you can compensate doctors well enough, and make them, feel that they're working in a better resourced place, then this can overcome any potential hostile attitudes or discriminatory attitudes. I think that is probably an implication, but just like the double-edged sword effect of cash transfer programs in refugee crises, one would have to be careful with that. It's been shown that when refugees get cash transfers, benefit from cash transfer programs, local communities start to get upset because they feel that they're not benefiting from it, even though the cash transfer does have a positive economic benefit on the local economy, on net. And so this is one thing that I think we'd have to sort of take with caution here is, incentivizing doctors through this kinds of extrinsic motivation can breed resentment, within the professional class as well. And so the notion of quality is a really good question. We do have other measures of quality that are subjective. How well did the doctor listen to you? Did the doctor treat you with care and empathy? Do you feel that you understood what the doctor said well? So we have a whole battery of subjective quality measures as well. And now I'm trying to rack my brains. It's in the supplemental appendix. I wish I should have reread closely, but I'm pretty sure that the findings track here as well, and that we see some, convergence between the objective and the quote unquote objective and subjective measures that we had, objective being the ones that were gathered during clinical observations. But we did look at that, but I fully agree with what you're saying, that, there's much more to the patient doctor interaction than just like time spent. Did they perform the, necessary examinations and so forth. And I should also mention, and we do thank people in the acknowledgements here, that we benefited a lot from colleagues in Lebanon helping us to put together questions, including doctors at the Ministry of Public Health, that tracked sort of what you would expect from an average array of examinations in the clinical interaction. So that informed how we put together the measures of examinations and things like that.
Great, Melanie. Well, thank you so much. I just had a Zoom 2 hours ago with colleagues in Moldova, Poland, and Hungary talking about the response to the Ukrainian crisis. And I really would encourage you to think about transferring, because I'm not sure that these factors you're looking at are only in the developing countries. It's a very interesting and complex picture there too, as you probably know. So with, you know, signs of tension already in Hungary, for example. So anyway, it's a very rich topic. And but thank you so much for sharing your excellent paper with us. We really enjoyed this discussion, and yeah, all the best with your project in Belfast.
Great. Thank you so much. Thanks for inviting me. Thanks, everyone.
Thank you to everybody for attending. Take care. Bye.
Bye.